Good morning, everyone. This morning's virtual cardiac rounds will be presented by our esteemed colleague, Dr. Natalie Ho. Just a few reminders before we get started around 5 after 8. She will be presenting on the updating cardiac amyloidosis. I will be the moderator during the virtual cardiac rounds. Just a few reminders regarding our virtual cardiac rounds. The presentation is being recorded. During the presentation, make sure your microphone is muted at all times. Questions can be asked at the end of the presentation. You can either use the raise your hand function or type them into the chat box, and I'll get to them as soon as possible. Thank you for your participation. We'll get started in a couple of minutes. Dr. Hope.
Great.
Compressed air.
All right, everyone, we're just about to get started. So good morning, everyone. This morning's virtual regional cardiac rounds will be presented by our esteemed colleague, Dr. Natalie Ho. She will be presenting on update in cardiac amyloidosis. Good morning, everyone. All yours, Dr. Ho.
Great. Thank you for the introduction, Chris, and welcome everyone on this very snowy December 1st. Here are my disclosures. So thank you for allowing me to present to you on cardiac amyloidosis. Many of you will recall that I spoke about this about 1.5 years ago. I am not recycling my presentation, but in fact, there has been an explosion of literature on this topic since then. The approval of a TTR stabilizer happened by Health Canada in January, and we're very excited to be announcing our very own Scarborough Health Network Cardiac Amyloidosis Clinic. So I have a lot to share with you, a lot of new things to share with you this morning. A lot of the content of my talk will be coming from a recent position statement published in the CJC in March of this year. So let's start with some cases. So here we have some images from a 71-year-old male who is actually a refugee from Afghanistan. Just let you enjoy those echo images. and we will come back to the cases at the end of the talk. Here is his diastology. Tissue Doppler along the mitral valve annulus on the lateral side and the medial side. E over E prime is over 25 in both the lateral and mitral annulus. Here are the measurements. So interventricular septal diameters measuring 2.2 centimeters. Here is his global longitudinal strain pattern. So I'll give you some background on this patient. He's 71 years old. He presents with dyspnea and pedal edema. He has a past history of hypertension, type 2 diabetes, and prostate cancer. He is slightly hypotensive at 100 over 70, heart rate of 80 beats per minute. JVP is elevated. He has 2+ pitting edema. So his echo, as you saw, showed severe LVH with reduced global longitudinal strain, with sparing of the LV apex and a ratio of the apex to the sum of the mid and basal segments more than 1. His SPEP and UPEP were negative for an M spike, and his serum-free light chain analysis showed a kappa to lambda ratio of 0.2. His technetium pyrophosphate scan was equivocal. So with this case, what is the next best test to determine the etiology of his heart failure? I'll ask that you just keep in your mind what you would think, and we are going to go over the answers at the end of the talk. So going into question number 2, here is a 65-year-old African-American male who presents with shortness of breath on exertion. He has a history of bilateral carpal tunnel release surgery 8 years ago. He has a history of hypertension, but his medications were stopped about a year ago because his blood pressure normalized. He had a negative angiogram, which was done about a month ago to work up shortness of breath when he presented to the eMERGE, and he had a mild troponin elevation. His physical exam is significant for normal blood pressure. However, it drops when he stands up. His JVP is about 4 centimeters above the sternal angle. His lungs are clear and he has no pitting edema. I don't have his echo images here, but the report showed an interventricular septal diameter of 1.3 centimeters, normal LV function, and grade 2 diastolic dysfunction. ECG shows normal sinus rhythm, no chamber hypertrophy. And on his technetium pyrophosphate scan, his report said that it was equivocal for ATTR amyloidosis. He also had a normal kappa to lambda ratio with serum free light chain analysis and a negative SPEP and UPEP. So what is the next appropriate step in this gentleman? Should we get genetic testing for hereditary ATTR, do a biopsy, get a cardiac MRI, or repeat his echo with strain, or do a fat pad biopsy? And I have a third question, the third and last one. So this is an 85-year-old male. He has wild type ATTR amyloidosis, confirmed. He has an EF of 35%, and he presents with progressive shortness of breath and orthostatic lightheadedness. His current medications include carvedilol, 12.5 milligrams PO BID, Lasix, 40 milligrams daily, spironolactone, and digoxin. He looks unwell on exam. His blood pressure is quite low at 85 on 60. Heart rate is 100. He is satting well on room air. JVP is elevated, and he has 1+ pitting edema bilaterally. His labs are as shown below, and his ECG shows sinus tachycardia. So in this gentleman, who appears to be volume overloaded, what would be the next step for him to feel better? Should we stop the carvedilol and add ivabradine? Should we stop carvedilol and increase digoxin? Should we increase his Lasix to 40 milligrams PO BID? Or should we stop carvedilol and digoxin and consider midodrine, 5 milligrams PO TID? Or should we do C and D? So let's jump into the content of this talk, and we'll go back into the questions at the end. So amyloidosis is a generic term for a heterogeneous group of diseases caused by the extracellular deposition of insoluble amyloid fibrils into different organ systems. Amyloid fibrils are formed from the misfolding of autologous proteins that then form abnormal oligomers, which in turn autologously assemble into amyloid fibrils. The fibrils are resistant to proteolysis, and thus they remain deposited in the extracellular spaces of organs and tissues, resulting in direct toxicity as well as alteration of the normal architecture of the organ, eventually resulting in organ impairment. What causes these proteins to misfold is unclear and thought to be influenced by a number of different factors, such as genetic predisposition, the presence of inherently unstable amyloidogenic proteins, and increased protein concentrations or advanced age. So in this illustration, on the left are 3D structures of different autologous proteins with amyloidogenic properties when they misfold. They form polypeptide chains that converge into these cross-beta sheet protofilaments, which then wind around each other to form amyloid fibrils, which have a characteristic width of 7.5 to 10 nanometers on electron microscopy. So over 30 human proteins have been identified as being amyloidogenic, with a tropism for various different organs. The ones that I've highlighted in this box have a predilection for the heart and have been described to cause cardiac amyloidosis. The organ tropism of specific amyloidogenic proteins will give rise to the distinct but often overlapping clinical syndromes. The two most common types of amyloidosis affecting the heart are AL amyloidosis and ATTR amyloidosis. The proper nomenclature uses an initial A to stand for amyloidosis, and the following letters stand for the amyloidogenic protein. In the case of AL amyloidosis, the L stands for immunoglobulin light chains, and in ATTR, the TTR stands for transthyretin. These two forms account for over 95% of all cardiac amyloidosis. As most of you know, AL amyloidosis is caused by a clonal plasma cell disorder, resulting in higher concentrations of circulating immunoglobulin light chains, either kappa or lambda, but most commonly lambda. The incidence is approximately 12 persons per million per year. These light chains misfold and form amyloid oligomers and amyloid fibrils that deposit in multiple end organs and cause multi-organ disease in the majority of cases. The majority of cases are associated with blood dyscrasias. For example, multiple myeloma is the one that we often think about, but this can also occur in Waldenstrom's macroglobulinemia and in non-Hodgkin's lymphoma. Up to 30% of cases of multiple myeloma will progress to AL amyloidosis, and up to 20% of cases of AL amyloidosis have multiple myeloma. Unlike multiple myeloma, most cases of AL amyloidosis have less than 20% plasma cells in the bone marrow, and AL does not typically present with the features of multiple myeloma, these so-called CRAB symptoms. As I mentioned, cases often present with multi-organ involvement, but usually one organ predominates. Renal dysfunction is very common and often presents with a nephrotic syndrome and albuminuria. The periorbital bruising that we see from the very fragile capillaries and macroglossia is really pathognomonic for AL amyloidosis, but not present in all patients. So the absence does not mean that they do not have AL amyloidosis. So infiltration of the myocardium with light chains and light chain oligomers can cause disease both from direct cellular damage, from oxidation from reactive oxygen species, stress kinase activation, and also deposition of amyloid fibrils can cause structural damage purely from the alteration of the myocyte architecture and the leading to the typical restrictive cardiomyopathy. As you can see in this gross specimen, we see a thickening of the myocardium and a very glossy appearance of the atrium where amyloid has diffusely deposited. So switching gears to transthyretin amyloidosis. Transthyretin, or TTR, is a protein produced mostly in the liver, with small amounts produced in the choroid plexus and retinal epithelial cells. It functions as a carrier protein for thyroxine and holoretinol binding protein. TTR is composed of 4 beta sheet-rich monomers that circulate as a soluble tetramer. Under physiologic conditions, there's really negligible dissociation into amyloidogenic monomers. However, this can be accelerated as the result of either genetic variation in the TTR gene or through currently unclear pathologic mechanisms of aging. Misfolding of the monomers results in aggregation into small oligomers and subsequently into amyloid fibrils. Deposition of these amyloid fibrils into the heart leads to transthyretin cardiac amyloidosis, or ATTR-CM. ATTR-CM is an under-recognized cause of heart failure. 2 forms of this exist. In hereditary ATTR, or hATTR, there is an inherited mutation that predisposes to the misfolding of TTR protein. In wild-type ATTR, the native TTR becomes kinetically unstable for reasons as yet unknown and aggregates into amyloid fibrils. It is important for us to delineate between wild-type and hereditary TTR because of clinical differences in phenotype, prognosis, and implications for screening of family members. The overall incidence and prevalence is difficult to ascertain due to challenges in diagnosis and likely previous underappreciation of the disease. So wild-type ATTR cardiomyopathy is increasingly identified worldwide and is almost exclusively a disease in the elderly, with an average age at diagnosis of 74 years. There is a significant male predominance with a ratio of 25 and up to 50 to every 1 female. Cases are seen worldwide with no specific ethnicity being more affected. Autopsy studies demonstrate a prevalence of up to 20 to 25% of patients over the age of 80 years. The percentage that actually manifests disease is unclear, but it was found that wild-type ATTR accounts for 13% of HFpEF cases in elderly patients greater than or equal to 60 years of age. The most common clinical presentation of wild-type ATTR cardiomyopathy is heart failure, with the majority presenting with a restrictive cardiomyopathy and preserved ejection fraction. But 30 to 50% can have reduced ejection fractions and LVEFs of less than 40%. Soft tissue involvement is common, including carpal tunnel syndrome, which is often bilateral. And up to 50% of patients referred with wild-type ATTR cardiomyopathy have preceding carpal tunnel syndrome or surgery that often precedes overt cardiomyopathy by an average of 5 to 10 years. A study where all tenosynovium from CTS surgery was sent for pathology with Congo red staining showed that 10% were found to have amyloidosis. Other soft tissue involvement, including lumbar spinal stenosis and spontaneous biceps tendon rupture, is also common. Wild-type ATTR can also present with conduction disease, including atrial arrhythmias like atrial fibrillation, atypical flutter, or atrial tachycardia, and heart block, with up to a third requiring pacemaker. Patients with wild-type ATTR cardiomyopathy are often misdiagnosed with other causes of LVH. Among patients over the age of 65 referred for TAVR, technetium pyrophosphate scanning revealed that 15% had uptake consistent with ATTR cardiomyopathy. And of those patients, 62% of those cases had low flow, low gradient, severe aortic stenosis. 20 to 25% of patients with wild-type ATTR cardiomyopathy also have asymmetric septal hypertrophy, and 5% of those diagnosed with HCM in fact carry a TTR gene mutation, and was found to have, and those 5 of those people, they were found to have ATTR cardiomyopathy on bone scintigraphy, as well as CMR. So hereditary ATTR accounts for approximately 5% of all systemic amyloidosis. The TTR gene is located on chromosome 19 and is highly polymorphic, with 130 out of 140 variants considered amyloidogenic. Each amyloidogenic mutation is believed to have arisen from a genetic founder, with population enrichment of the affected allele in certain geographic regions based on migration patterns. So hATTR amyloidosis is transmitted in an autosomal dominant manner with variable penetrance. Certain variants typically result in cardiomyopathy, while others have predominant peripheral neuropathy, and some will have a mixed phenotype. You will notice, for those of you who have sent genetic testing off, that published data nomenclature often differs from the nomenclature that you see on the genetic reports that you receive. And this is due to a 20 amino acid signal peptide that is excised to form the mature protein. So I will speak briefly about 3 of the most common mutations in the next 3 slides. I won't go into too much detail on each of them or on the other genetic mutations. So the most common variant worldwide is Val30Met. It was initially observed in a Portuguese family who presented with neuropathic symptoms. However, this mutation has gone on to be identified in various populations all over the world, including Greece, Japan, and Sweden. 2 presentations of the disease exist, with an early onset form that is seen in endemic areas, with presentation at ages less than 50 years, and predominantly presents with autonomic neuropathy and length-dependent small fiber polyneuropathy. Late onset disease is seen in non-endemic areas and presents in patients over age of 50 most commonly, and have mild autonomic symptoms and are more likely to manifest cardiomyopathy. The second most common mutation in the world is Val122ILE and is almost exclusively seen in individuals of West African and Caribbean origin, with 3.4% of African Americans carrying this gene. The phenotype is very similar to wild-type ATTR cardiomyopathy in that it often presents as a late-onset cardiomyopathy and uncommonly causes polyneuropathy. Recent reports suggest a 10 to 20% penetrance, but this is really based on the methodology used to define disease. Threonine 60-alanine is the second most common mutation in the US and originates in the northern part of the Republic of Ireland. This causes a mixed phenotype with a high rate of carpal tunnel syndrome and cardiomyopathy. So this is a table just summarizing the differences between hereditary ATTR cardiomyopathy and wild-type ATTR cardiomyopathy. As you can see, the clinical presentation is slightly different. And in hereditary ATTR cardiomyopathy, the presentation really depends on the gene mutation. There exist many challenges to the diagnosis of ATTR cardiomyopathy. First, the clinical phenotype of wall thickening and heart failure is often attributed to other common diseases, such as hypertension, aortic stenosis, and hypertrophic cardiomyopathy. There's also a perceived rarity of the ATTR cardiomyopathy disease and a subsequent therapeutic nihilism, especially as previously this disease was believed to be untreatable. As a result, it is very important to have a low threshold for thinking about ATTR cardiomyopathy. And many of you will have seen many different lists of red flags for thinking about ATTR cardiomyopathy. Here is one that was published in the recent position statement in the Canadian Journal of Cardiology. So definitely those people who have increased LV wall thickness on echo with low voltages on ECG think about cardiac amyloidosis. However, do keep in mind that only 25 to 40% will meet the criteria for low voltage on their ECG. So even if you have high voltages, don't discount amyloidosis. Think about this in patients who present to you with a natural cure of their hypertension. So they've had a need to down titrate or discontinue antihypertensive therapies recently. Patients who have a history of heart failure but a recent intolerance to beta blockade, do think about amyloidosis. For sure, those with carpal tunnel syndrome, prior lumbar spinal stenosis or biceps tendon rupture, patients with unexplained peripheral or autonomic neuropathy, and those with persistently positive cardiac enzymes in the absence of coronary artery disease. The CCS position paper on cardiac amyloidosis recommends workup for cardiac amyloidosis for patients with new onset heart failure and any one of these, which is pretty similar to the list I just went through. Definitely those with low flow, low gradient aortic stenosis, we are identifying that up to 15% of these people have cardiac amyloidosis. So think about it, consider doing technetium pyrophosphate scanning. So when to expect hereditary ATTR cardiomyopathy? So those with progressive sensory motor neuropathy, like for example, relentless progressive distal to proximal small fiber neuropathy, those with bilateral carpal tunnel syndrome, GI complaints, especially unexplained weight loss or a alteration between chronic diarrhea and constipation. Patients with hereditary ATTR cardiomyopathy have early autonomic dysfunction with postural hypotension, erectile dysfunction. They can have ocular abnormalities like early cataracts, vitreous abnormalities, and for sure the cardiac signs and symptoms that we just went through. So the recent position statement goes through a diagnostic algorithm for the evaluation of suspected cardiac amyloidosis. And I want to go through this algorithm with you all in a stepwise approach. So the first step is really to suspect the diagnosis based on the red flags that we've just gone through. So once you've suspected the diagnosis, you start with a standard heart failure workup, including BNP, and in our institution, it is BNP and an ECG, and then conducting imaging to help evaluate for characteristic features of cardiac amyloidosis. And ideally, having echocardiography with global longitudinal strain can be very helpful. Keep in mind that echo and cardiac MRI are not able to distinguish between the types of cardiac amyloidosis, either AL or ATTR amyloidosis. So then once you have imaging evidence and clinical possibility of cardiac amyloidosis, the next step is really to rule out a plasma cell dyscrasia. And the reason why this is so important is that AL amyloidosis has a much poorer prognosis compared to ATTR amyloidosis and is reportedly 6 months average survival without treatment. So it is very important to keep in mind that SPEP and UPEP are insensitive to detect AL amyloidosis, and quantification of serum-free light chains is really required. Once you have demonstrated an abnormal serum-free light chain ratio, the next step is immediate referral to hematology and the need for a tissue biopsy to show light chain amyloid deposits in any organ, not necessarily the heart. Usually that will be the bone marrow. Biopsies should be sent for mass spectrometry or immunohistochemistry and immunofluorescence, which can be done at Toronto General Hospital. So it's very important to flag the pathology department to keep specimens to send downtown. So if after this workup, your suspicion for cardiac amyloidosis is still very high, the next step would be to get an endomyocardial biopsy. Once you've ruled out AL amyloidosis, the next step is to assess for ATTR cardiac amyloidosis. Bone avid tracers have really revolutionized our ability to diagnose ATTR cardiomyopathy and confer 100% specificity for ATTR cardiomyopathy when grade 2 or 3 uptake is seen in the setting of typical echo or MRI features of amyloidosis and in the absence of a monoclonal gammopathy with no need for cardiac biopsy. So this is a pictorial display of the different imaging modalities available in the workup of cardiac amyloidosis. The ECG is the least sensitive or specific, but can demonstrate low voltages, as I mentioned, in 25 to 40% of cases, and can also identify atrial arrhythmias or conduction disease. Echo features of cardiac amyloidosis include LVH, typically more than 1.2 centimeters, preserved ventricular size with biatrial enlargement, diastolic dysfunction, and valvular thickening, and often people have a small pericardial effusion, but very rarely do they progress to tamponade. The classical apical sparing on longitudinal strain with the cherry on top has been well described in the literature to be sensitive and specific for for cardiac amyloidosis. However, the absence of that does not rule out cardiac amyloidosis. Cardiac MRI can show diffuse, transmural, or subendocardial late gadolinium enhancement. And the key word when you're reading your cardiac MRI reports is to see that there is abnormal gadolinium kinetics. That is very suggestive of cardiac amyloidosis. There's a lot of data on pre-contrast T1, native T1 time, which is very prolonged in cardiac amyloidosis, and an elevated extracellular volume fraction, which just speaks towards the expanded extracellular space in cardiac amyloidosis, and potentially could be one method of monitoring disease progression in patients with cardiac amyloidosis. So nuclear scintigraphy with bone-avid tracers is a non-invasive imaging modality that can be used to diagnose myocardial involvement of transthyretin amyloidosis without the need for cardiac biopsy, as I mentioned. It is really the only non-invasive imaging modality that can differentiate the type of cardiac amyloidosis. Radiotracers that were originally designed as bone tracers were actually found to localize to cardiac amyloidosis in the 1970s. The mechanism underlying the myocardial retention of tracers is unknown, but possibly attributed to the presence of microcalcifications that are more common in ATTR than in AL cardiac tissue. Perugini created a semi-quantitative scheme comparing the amount of tracer uptake in heart compared to rib, and created a 4-point grading scale, with 0 being no uptake, grade 1 being less uptake than rib, grade 2 is equal uptake to rib, and grade 3 is cardiac uptake exceeding bone uptake. There is also a quantitative scheme that is used where a region of interest is drawn around the heart and a comparable region of interest is drawn on the contralateral lung. And a quantitative grade or ratio of more than 1.5 is considered significant. In this study by Bokhari, he showed that ATTR cardiomyopathy has much higher radiotracer uptake compared to AL cardiac amyloidosis. However, keep in mind that there is some uptake in AL amyloidosis, and therefore technetium pyrophosphate scans cannot be used to rule out AL amyloidosis. And that is why serum and urine screening for monoclonal proteins is important for all patients suspected of having cardiac amyloidosis. So keep in mind that the definitive diagnosis of cardiac amyloidosis, when your testing doesn't match, and yet your clinical suspicion remains high, is to get an endomyocardial biopsy. As long as at least 4 different sites are biopsied, this has nearly 100% sensitivity and specificity. Fat pad biopsies are very available, and we have a great general surgeon at Scarborough General who has offered to help us with all of our fat pad biopsies, but these only have 15% sensitivity. So it's important to keep in mind a couple of things when you are working someone up for cardiac amyloidosis. So first of all, as I mentioned, AL cardiac amyloidosis can lead to grade 1 or higher grades of cardiac uptake on bone scintigraphy. And 40 to 50% of ATTR cardiomyopathy do have coexistent and unrelated MGUS. And hence it is important in these situations to have tissue diagnosis for AL amyloidosis, which can be confirmed with the immunohistochemistry. Also keep in mind that tracer uptake on bone scintigraphy can be sparse or absent in patients with definitive cardiomyopathy related to rare mutations, such as the Phe64 leucine mutation. So prognosis in ATTR cardiomyopathy really depends on the type of ATTRs, cardiac amyloidosis people have. Wild-type ATTR cardiomyopathy has a median survival from diagnosis in untreated patients that is consistently around 3.5 years, but really dependent on the stage of disease that they present in. Echocardiographic findings such as wall thickness, left ventricular mass index, and diastolic function are not really independent predictors of survival. And for hereditary ATTR, most series looking at survival report a median survival for those presenting with primarily polyneuropathy of 8 to 10 years, and those with heart failure of 2.5 to 3.5 years, which is very similar to the wild-type cardiomyopathy. So there are two proposed staging systems for TTR cardiomyopathy. This first one was proposed by Martha Grogan and includes troponin and NT-proBNP and divides patients into 3 stages based on whether or not they meet both troponin and NT-proBNP cutoffs, or only one of those cutoffs, or neither of those cutoffs. Oh, I'm sorry. I thought I had another slide. So there is another staging system that was created by Gilmore, and the Gilmore staging system includes NT-proBNP and EGFR. This is thought to be a better staging system because in ATTR cardiomyopathy, troponin T tends not to be as good of a marker of disease stage as EGFR because there's less of the direct toxicity of TTR fibrils to the cardiac myocytes as there are in AL amyloidosis. So in AL amyloidosis, the Mayo staging system, which includes troponin and NT-proBNP, is more used, whereas in the ATTR cardiomyopathy, a staging system involving NT-proBNP and EGFR is probably more predictive of survival. So moving on to medical management in cardiac amyloidosis, there are 2 main components of managing your patient with cardiac amyloidosis. The first is management of their heart failure and the cardiac sequelae of cardiac amyloidosis, and the second is disease-modifying therapy. So we'll start with looking at just the management of heart failure and cardiac amyloidosis. So cardiac amyloidosis is characterized by decreased ventricular capacitance and reduced stroke volume. And as a result, there is a very narrow window between being volume overloaded and hypovolemic. And maintenance of euvolemia is central, especially as patients will have a concomitant autonomic dysfunction and enhanced load lability. It's very easy to over-diurese your patient and get out of that window of euvolemia, resulting in rapid worsening of renal perfusion and worsening of renal function. In patients who have refractory edema not responding well to Lasix, consider using diuretics with more bioavailability in the setting of gut edema, for example, bumetanide. Patients often have very low stroke volumes, and thus they rely heavily on heart rates to maintain their cardiac output. As such, they have a very narrow window of optimal heart rate and will decompensate when heart rate goes too slow or goes above this, which is really why patients with cardiac amyloidosis do not tolerate beta blockers very well. Keep in mind that patients have a very high risk of left atrial thrombus due to the mechanical dysfunction of their atria. And patients, even in sinus rhythm, have been found to have left atrial thrombus. And therefore, one must have a very low threshold for anticoagulation in any atrial arrhythmia in cardiac amyloidosis. Digoxin and non-dihydropyridine calcium channel blockers are also relatively contraindicated in cardiac amyloidosis, as it is thought that these will bind to fibrils, resulting in earlier toxicity. Patients with cardiac amyloidosis often present with arrhythmias, which can be very difficult to manage. These arrhythmias range from bradyarrhythmias, atrial fibrillation, to ventricular arrhythmias, as illustrated in this diagram. Bradyarrhythmias secondary to sinus node and conduction system infiltration are very common. Up to 1/3 will require pacemakers. And in general, there are no disease-specific recommendations for guiding pacemaker placement in cardiac amyloidosis, so usual indications are used. Atrial fibrillation occurs in 44 to 70% of patients with cardiac amyloidosis and can be very difficult to control, as most patients will be very intolerant to AV nodal blocking agents such as beta blockers. So amiodarone has been reported to be used, but can increase the rate of AV nodal blockade, so do keep that in mind. When all else has failed, you've failed rate control and rhythm control, you can consider ablation. This has been reported in the literature with a moderate success rate and a 60% 3-year recurrence-free survival. At the end of the day, if you're really unable to control rates, consideration could be made for AV nodal ablation and a pacemaker. Non-sustained ventricular tachycardia is common in cardiac amyloidosis. However, sustained VT or ventricular fibrillation is thought to be less common. Studies looking at the rates of appropriate ICD therapies in patients with cardiac amyloidosis has been very variable. There is a suggestion that patients with AL amyloidosis have higher rates of appropriate shocks, and indeed those with a history of prior cardiac arrest or ventricular arrhythmias will also be more likely to have appropriate ICD discharges. But in general, no study has shown that ICDs make any difference in terms of survival. So here are 2 proposed algorithms from the Heart Rhythm Society for the management of ventricular arrhythmias in the prevention of sudden death in patients with cardiac amyloidosis. In general, there's really only a class 1 indication for secondary prevention in patients who have an expected survival of more than 1 year. And in terms of, secondary prevention. In terms of primary prevention, this is really only a class 2B recommendation for patients with AL amyloidosis who have a likelihood of meaning survival of more than 1 year, possibly because they are on treatment. So I'm just cognizant of the time. We're coming up to 8:45, so I'm going to move quickly through the next few slides on disease-modifying therapy. I will note that the CCS position statement did recommend heart transplantation to be reserved only for those patients with really isolated cardiac manifestations of their amyloidosis, with and if they are, for example, AL amyloidosis, they're on treatment with, for example, the option of stem cell therapy. But otherwise, transplant is really not considered in most patients due to their multiple comorbidities. So therapeutic strategies for ATTR cardiomyopathy are listed here in this diagram. And there are different agents that are used and target different stages of the formation of transthyretin. So we have in the initial part of this diagram, the TTR silencers, which are patisiran and inotersen. And these basically inhibit the RNA that codes for TTR. The next is TTR stabilizers, or tafamidis, which is the one that we are most familiar with and has been approved by Health Canada. And finally, in the end of this cascade, we've got medications that are aimed at disrupting amyloid fibril formation, such as doxycycline and ursodeoxycholic acid. So tafamidis is recommended for patients with ATTR cardiac amyloidosis and NYHA class 1 to 3 symptoms, and is really not recommended in NYHA class 4 symptoms. Treatment with TTR RNA silencing agents such as patisiran or inotersen is recommended and really only studied presently in hereditary ATTR cardiac amyloidosis with ambulatory polyneuropathy. However, there is data to show that they may reduce LVH and LV wall thickness, and there are current studies that are looking at specifically at the use of these TTR RNA silencing agents in patients with cardiomyopathy. In patients with hereditary ATTR cardiomyopathy and a mixed phenotype, the choice of TTR RNA silencing agents versus tafamidis should really be individualized and made in conjunction with neurology, considering the toxicity profile, the ease of administration, and the dominant phenotype plaguing this patient. Combination therapy with tafamidis and TTR RNA silencers makes a lot of intuitive sense, but this has not yet been evaluated. So tafamidis is the one TTR stabilizer that has been approved by Health Canada for the treatment of ATTR cardiomyopathy and was well studied in the ATTRACT study, looking at 2 doses of tafamidis, 20 milligrams or 80 milligrams, and comparing this with placebo. In the ATTRACT results, tafamidis was associated with a 30% reduction in the risk of all-cause mortality compared with placebo, and had a 30% reduction in cardiovascular hospitalizations and performed best in patients with NYHA class 1 to 2 symptoms. And this separation of the curves really occurred at 18 months. There is also symptom benefit with tafamidis, which was identified at 6 months with improved 6-minute walk test and improved quality of life scores. So the authors concluded that in patients with ATTR cardiomyopathy, tafamidis reduces all-cause mortality as long as patients can survive the 18 months when it was demonstrated in the study. Tafamidis is definitely not the panacea for a cardiac amyloidosis. It can help reduce functional decline by 6 months, but it is very important when you are speaking to your patients not to paint a very rosy picture of this drug yet. Hopefully, as more research goes into other TTR stabilizers, maybe that have more affinity to transthyretin, we can have better outcomes. But for sure, this is the one drug that we currently have available that can meaningfully change survival and quality of life. So diflunisal is a non-steroidal anti-inflammatory drug that has been repurposed as a TTR kinetic stabilizer. There have been phase 3 randomized placebo-controlled trials looking at diflunisal in hereditary ATTR polyneuropathy and found that it is well tolerated, but it is difficult to prescribe these to our patients with TTR cardiomyopathy because they often have significant problems with volume overload and renal dysfunction, which can be a problem when giving NSAIDs. For the sake of time, I'm not going to go into the gene silencers, but there are 2 gene silencers available. Patisiran is a small interfering RNA that targets TTR mRNA synthesis, and inotersen is a antisense oligonucleotide that prevents the transcription of TTR RNA to protein. Very interestingly, doxycycline, very common antibiotic, actually has a homology to anthracyclines, and anthracyclines have been found to promote amyloid fibril resorption. And so there have been some small studies looking at doxycycline in the treatment of cardiac amyloidosis. Doxycycline will help remove fibrillar TTR deposits, but it does not reduce non-fibrillar TTR deposits. However, ursodeoxycholic acid, or tauroursodeoxycholic acid, has been found to reduce non-fibrillar TTR deposits, and therefore the combination of doxycycline and tauroursodeoxycholic acid has been found to synergistically help remove deposited amyloid fibrils. This has really only been shown in small studies. One observational single-center cohort study out of Calgary reported the off-label use of doxycycline and urso and found that after 22 months of mean follow-up, there was a significant improvement in global longitudinal strain in patients who began with higher global longitudinal strain. So really only helpful in patients who are less advanced in their disease. So in the next few minutes, I want to take the opportunity to introduce to you our new Scarborough Health Network Cardiac Amyloidosis Clinic. Our vision is to provide local diagnostic testing for the timely diagnosis of cardiac amyloidosis and promote patients in Scarborough and Durham region to have access to treatment and multidisciplinary care. We hope to provide patients and families with education and support and really work with our community to advance our current understanding of this very new disease that we are becoming more aware of through the centralization of care, and hopefully to participate in research as well. Cardiac amyloidosis is definitely a multi-system disease that requires multidisciplinary approach to care. And so we have formed a cardiac amyloidosis clinic network at the SHN to provide patients with care in all of these different disciplines. We are able to provide local EMG studies at the Scarborough General Hospital. Technetium pyrophosphate scans are done at the Birchmount site, and cardiac MRI is done at Centenary. We've also established a relationship with genetic testing at Lakeridge Hospital. And the clinic itself will be located at the Scarborough General Hospital. So who should be referred to the SHN Cardiac Amyloidosis Clinic? So any patient with red flags for cardiac amyloidosis, as I went through earlier on. Patients with patients with amyloidosis of another affected organ should be referred to screen for cardiac involvement. Patients with multiple myeloma for rule out of cardiac amyloidosis, and family members of patients with confirmed hereditary ATTR cardiac amyloidosis can be referred for screening and long-term monitoring for the development of disease. So this is a proposed clinic flow, and we do hope to partner with community all cardiologists to co-manage patients with cardiac amyloidosis. So how to refer to our clinic? We are in the process of creating our own referral form. This may take until EPIC is up and running, but in the meantime, please fill out a general referral form and send it to our Heart Function Clinic fax number. So in the last few minutes, I'll just go back through our cases. So our question 1 was this patient who had a very abnormal echo. You'll notice that he has very reduced annular motion, which can be very suggestive of cardiac amyloidosis. So the key thing for this man was that his technetium pyrophosphate scan was equivocal, but he had an abnormal kappa to lambda ratio. So this should really trigger people to order a bone marrow biopsy to look for AL amyloidosis and with Congo red staining and hopefully immunohistochemistry. So question 2 was a 65-year-old African-American male who had prior carpal tunnel syndrome, so very suggestive of cardiac amyloidosis, specifically TTR amyloidosis. Now, his technetium pyrophosphate scan was equivocal. So does this rule out TTR cardiac amyloidosis in him? Well, our suspicion is high enough that it is important to go back to the algorithm. And when you look at the workup that has been done, the echo imaging, while it did show evidence of hypertrophy with an interventricular septum measuring 1.3 centimeters, there was no assessment of strain or other advanced imaging to increase our suspicion for cardiac amyloidosis. So this would really be a next step. And if this is highly suggestive, then consideration should be made for biopsy and getting tissue to confirm cardiac amyloidosis. And from there, maybe genetic testing. So question 3 was really a question about management of patients who are suffering from severe heart failure and cardiac amyloidosis. And the key with this patient is that he is on a number of guideline-directed medical therapy for the treatment of heart failure, but these are really not well tolerated, as I mentioned, in cardiac amyloidosis. So we really should be stopping his carvedilol, definitely not slowing his heart rate anymore, and consideration could be made for midodrine to help improve blood pressure to allow for diuresis and getting him more euvolemic. All right, so cardiac amyloidosis is an under-recognized cause of heart failure. It requires a low threshold for suspicion for early diagnosis, and a methodical approach is important for diagnosing this elusive disease. And disease-modifying treatments do exist and will soon be widely available for our patients. Thank you.
Thank you, Dr. Ho, for that very informative cardiac rounds. We'll move into the question and answer period. For those who have any questions, you can use the raise your hand function, or you could type it into the meeting chat, and we'll keep it open for a couple of minutes so those who want to ask questions can. Thank you. Dr. Ho, we do have a question. It says, what is the cost of, I'm not sure if I pronounced this correctly, tafamidis?
Yeah,
I think it's a drug.
So I had a patient who recently spoke to the Pfizer Patient Support Program, and he was told it would be $30,000. He has no drug coverage. So without drug coverage, it is almost impossible to get tafamidis. But hopefully there will be some programs for our patients. I know that there are current talks looking at each of the individual public funders per province. And there are good drug plans, actually, now that it has been approved by Health Canada. Specific drug plans, I know that Sun Life will pay for it for patients. So it's important, if you have a patient who you think would be a candidate for tafamidis, to have them fill out or connect with Pfizer, and they can look into whether or not patients have drug plans that will cover.
Excellent, thank you. We have another question. Are you liaisoning with the UHN clinic in any way?
Yeah, so Dr. Delgado has been very instrumental in helping us set up our clinic, and he's very much sort of like a hub and spoke kind of model, where definitely they are the ones who have a lot of trials going on, and so we hope to be able to work with them to identify patients who can be enrolled in different trials and have access to newer therapies. So we are working with UHN definitely.
Excellent. We'll leave it open for another 30 seconds, and then we'll say our goodbyes. Dr. John Mohammed says, excellent summary and review, Natalie.
Great, thanks, Amir.
All right, so that ends this morning's virtual cardiac rounds. I want to thank you, Dr. Natalie Ho, for this morning's presentation. And I believe we have one more cardiac rounds next week for this year. Don't quote me, but I think we have one more for the rest of the year. So we'll see everyone back next week. Thank you, everyone. Have a good one.
Thanks, everyone.